Okay, next paper is rapid fire, and it's live. The effect of socioeconomic status on amputation outcomes and limb salvage intervention, to be presented by Dr. Buckley and colleagues from MUSC. Welcome.
Good afternoon, and thank you for the opportunity. I have no disclosures. So older Medicare data suggests that racial minorities have decreased rates of limb salvage attempts prior to major limb loss, which is seemingly amplified in the southeastern United States. Other studies have suggested an interplay between race and socioeconomic status contributing to the decreased access to higher level vascular care. We sought to determine among patients who undergo major amputations if socioeconomic status and race are associated with differences in baseline comorbidities, rates of limb salvage attempts, and level of amputation. The VQI was queried for patients who underwent below-knee and above-knee amputations from 2012 to 2020 for the indications of rest pain and tissue loss. Data was queried about baseline demographics, socioeconomic status based on the DCI, comorbidities, vascular interventions prior to limb loss, level of amputation, and third-day mortality. The following variables were compared across DCI and race: comorbidities, ipsilateral revascularization attempts, level of amputation, and 30-day mortality. The Distress Communities Index is a comprehensive calculation utilizing the seven variables on the left. It's formulated into a score between 0 and 100, with our highest scores being in the distressed tier and our lowest scores being in the prosperous tier. On the right, you can see the proportion of each stage population residing in the distressed zip codes. So when looking at our demographics by DCI, we see that we have an increased proportion of female patients in our more distressed groups, and we also see we have an increased proportion of younger patients, specifically less than the age of 70, in our more distressed groups. When looking at these demographics by race, we see that our Black and other minority groups have a higher proportion of female gender, as well as age less than 70. When analyzing comorbidities based on DCI tier, we see that we have an increased rate of patients who are underweight in our more distressed groups. Interestingly, cardiovascular comorbidities were similar, specifically CAD, although our more prosperous groups were more likely to undergo CABG. And PCI followed that same trend but did not reach significance. Our more distressed groups were more likely to be on dialysis and also underwent more urgent amputations. When looking at these same comorbidities based on racial group, we see that our Black and other minorities had a higher rate of being underweight, hypertension, as well as diabetes. And when looking at our indication and urgency, our minority groups had an increased rate of tissue loss as well as underwent more emergent amputations. The interplay between DCI and race is interesting, and we see that as we trend through our more distressed groups, we have an increased proportion of Black patients. When analyzing these outcomes by DCI tier, the AKA rate significantly increases among all five groups, going from the prosperous to distressed tiers, while the prior intervention rate decreases through our prosperous and distressed tiers, with the lowest being the distressed tier. Our third-day mortality was similar for these groups. When looking at our outcomes by race, we see that our AKA rate was highest among our Black patients, while the prior intervention rate was lowest in our Black and other minority groups. Our 30-day mortality among these groups was statistically significant and different, and with the minority group having the highest at 7.8. Our multivariable analysis demonstrated that DCI tier is an independent predictor of above-knee amputation, with the odds ratio increasing as we get through to our more distressed groups. Female gender, non-white race, dialysis, and prior smoking were also independent predictors of above-knee amputations. And when looking at this for prior interventions, we see DCI tier is also an independent predictor of undergoing a prior vascular intervention, with our prosperous group having the highest odds ratio of 1.55. And again, female gender, white race, dialysis, and smoking status were also independent predictors. In conclusion, patients in lower socioeconomic status who undergo amputations are typically younger, have higher rates of female gender malnourishment, and are more likely to be on dialysis. Minority patients who undergo amputations are more likely to be younger, have higher rates of female gender, diabetes, and tissue loss. Low socioeconomic status in Black race is associated with a significantly higher rate of above-knee amputation and a lower rate of prior vascular intervention. And when controlling for baseline differences, minorities and patients in lower socioeconomic status had an independent, significantly increased rate of AKA and lower rates of limb salvage attempts. Thank you.
The paper is open for discussion.
Hey there, very nice presentation. I love this. And thank you for delving into something besides race and what actually is a social determinant of health, so socioeconomic status. So my questions to you are, did you look at geographic differences? Could you divide the country into north, south, east, north, east and north, south, west, whatever? Anyway, but could you see differences in where different racial designated groups lived and what their outcome was? Neil Barshes from Houston published a paper in JVS a couple years ago looking at zip codes in Texas, and that the highest rates of amputation were zip codes in Houston, Texas, 2 miles away from the largest medical center, in the world. So I would invite you to look at geographic differences in that. And just one correction, female is sex. So if you're talking about males and females and chromosomal differences, it would be sex, not gender.
Okay.
So
To answer your question, we did originally ask for regional data from the VQI. They unfortunately wouldn't grant us that access. That's why we went with the DCI data, which we do, they do have maps on their website that show how, the zip codes and where the more distressed patients live amongst the United States, and in particular the proportion among each state. But we weren't granted the specific regional data from the VQI.
and my last question is, in your discussion, do you talk about why you think women, persons with female sex might have higher amputation rates?
We haven't fully finished the paper yet, but in terms of female gender, I think it's been pretty well documented that they have worsening vascular disease, more likely to be in the tibial region, and then generally present later, specifically in our region in the south.
I'll defer.
Misty Humphreys from UC Davis. I was wondering if you think VQI is the best data set for this. VQI is purchased by hospitals, and not a lot of hospitals in small rural areas or smaller hospitals have it. And that's sometimes where a lot of these patients get treated. So have you thought about using a different data set, and then you could do some things with geography as well? Because I just worry that you're still seeing a very selective group of patients that are going to some of these really skilled centers versus going to some of their first-line treatment places.
Right, and I think that's completely true. I mean, we know that the VQI is recorded by our big vascular centers, and I think if we were to look at the more rural hospitals where a lot of these patients in the more distressed communities are being seen, I think we'd see even higher level of primary amputations without prior vascular intervention.
Hi, William Schutz from Plano, Texas. I'd like to applaud you and your co-authors on a fantastic study and for looking into this really important issue. The difference between an AK and a BK is massive. I mean, this is function, this is quality of life, and more importantly, this is survival. I mean, the AKs have such an inferior survival to a BK. So this is really important to look at this and see what we're missing. I was hoping that the DCI would be the answer. And it's part of the answer, but we now know that there's also female sex, which I've learned from Dr. Bush now, to use the appropriate terminology, and also non-white race. So there's something else going on. And I'm going to ask a question you probably don't have the answer to, but is there some bias in the way we're treating our patients? And you don't have to answer that, but I mean, just think about it. Is there some bias? We found in our own practice when we looked at our prosthetics referral and survival that there was something else going on. I mean, we definitely saw some people that were at risk for non-referral. My hypothesis is that it was frailty, and that's something that's very hard to capture out of VQI, and perhaps it's not bias, it's not on us, but it's frailty that is driving these numbers. So I'd like to hear your thoughts on that.
I'd like to hope that we're not treating our patients in biased ways, but I think you're right in that this is a very complex issue that doesn't have a simple solution. I think, to chalk this up to just one thing, like patient finances, wouldn't be true, and it's more likely a complex interplay between finances, education, and as well as barriers in the social and cultural level that are really hard to battle, especially that we notice in our region in the Southeast.
Thank you very much. Very interesting paper.